It is now 12 o'clock. Welcome to Empro Insurance Company's presentation. I'm Dr. Tristan Muick, the Assistant Medical Director at Empro Insurance Company. If you're interested in telehealth, then you've definitely come to the right place, because today we'll have one of the preeminent world experts on telehealth, Dr. Joseph Kvedar, Chair of the American Telemedicine Association. Dr. Kvedar is also professor at Harvard Medical School. He's a senior advisor on virtual care at Mass General Brigham. He's the editor-in-chief for the prestigious journal Nature's digital medicine publication. He is also co-chair of the American Medical Association's Digital Medicine Payment Advisory Group, and he is a member of the Association of American Medical Colleges Telehealth Committee. So without further ado, I'd like to extend a warm welcome to you, Dr. Kvedar. Thank you for joining us here today.
Thank you, Tristan. I'm delighted to be able to share some remarks with your audience. And the way I think we should use the time is, as I will go through this content, it's really meant to start off with some of the very basics about telehealth and virtual visits. And as we go forward and through, we'll of course touch on some of the risk management aspects. That's what I know this audience cares deeply about. And then towards the end, more what's coming, what are the things coming down the pike that you should be aware of, that you should follow, that you should read about, etc. I don't expect to use the whole time for content. And if there are questions, people, I gather if you put your questions in the chat, some of the folks from Empro will help me with those as we go forward. If there aren't questions now, towards the end, I will leave my contact information if people want to follow up with me later. So that's sort of a preview of where we're headed today. I do want to start out by mentioning the American Telemedicine Association. As Tristan said, I'm head of the board there, chairman of the board. This is an organization that is advocating for the advancement of telehealth. Really, it's a rising tide floats all boats organization. It's your organization should be a part of it if you care at all about telehealth, because we are, as I was saying off camera before we started, we're just at the beginning. And that's another theme that I'll continue to share with you during my time today, is that if you think that sort of the virtual video visit with all the press that it's gotten and all the wonderfulness is the goal, I think we should immediately change our thinking that it's really just the beginning. And the ATA is an organization that will help us get there, and from a policy perspective and an educational perspective. Our annual meeting is coming up. It's in June. It's going to be all Tuesdays and Thursdays for 4 weeks, small snippets. As you all know by now, virtual meetings don't run well if you do days and days on end. So we're going to do short snippets. If you go to our website, americantelemed.org, you can find out more about the annual meeting. If you're more interested in this content today, that might be a good way to get a deep dive and learn more. We have some fabulous speakers and a lot of content for people of all levels of knowledge about telehealth. Right, so this is what we're going to cover today. And as I said, I'm going from sort of the nuts and bolts, building blocks, basic stuff, to all the way down. And as we go down this list, it's more and more the next phase. And of course, artificial intelligence is the last thing I'll finish with. I do think it's important to cover that. It's early enough in the market that I think the risk management aspects are really just beginning to come into focus. So I don't have a lot of practicality about AI, but you should know about it. You should understand that you should be thinking about how it's going to affect the care delivery process and the management of healthcare in general. Now, with that, I want to spend the first few minutes on this particular diagram. This is not a diagram that I created, but one that was created by colleagues of mine at the Massachusetts General Hospital Center for Telehealth. And I use it and explain it in some detail because what it's going to do is give us a common language, particularly about the area of telehealth. And as I've said, we're going to talk more about more than just pure telehealth, but the bulk of this is about telehealth. And so the way this diagram works is that the columns differentiate between something synchronous or real time, just like what we're doing now, versus something that in the vernacular of the telehealth crowd is store and forward. Another term we use is asynchronous. Both of those are sort of geeky terms, but if you think about the analogy between a phone call or a video call on the left-hand column and an email or a text message on the right-hand column. Again, I'm not suggesting that we do text messages with our patients, but just the asynchronous nature of that information exchange. And if it's real time, it's a virtual something. If it's asynchronous, it's an e-something. And the top row speaks to whether this is a conversation or care delivery between a patient and a clinician, in which case it's a visit. And then the bottom is between clinicians, in which case it's a consult. And I think those terms generally make sense. So if you had something like a virtual consult, that might be a telestroke interaction between an emergency room physician in one hospital and a neurologist in an academic center who's providing guidance on whether the patient has a stroke, whether to administer TPA, et cetera. Whereas an e-visit would be a patient, and we didn't mention this, but I'm a dermatologist myself, still practicing, and a patient might send me over the patient portal some history and some images of their skin, and I reply with some kind of care advice. That's an e-visit. So that's the idea behind this taxonomy. And again, I think it's important that we get that straightened out because it'll avoid confusion as we talk about it. Now, the bulk, one of the things that I often say at this stage is that prior to the pandemic, all of these terms, and unfortunately many more, we had e-health, m-health, digital health, and on and on and on, telehealth, telemedicine. People got confused over terminology. And they would all, what I would say is if there were a word cloud, they would all be represented relatively similarly. Since 1 year ago now, virtual visit is the big dog without question, and everyone thinks that's telehealth. There's some good and the bad and bad to that. And we'll discuss a little bit about some of those pros and cons, but it is the reality. And so for that reason, I'm going to spend a fair amount of time on virtual visits, but I do want to spend a short amount of time before that so that I don't forget and so that we address the notion of e-consults. This is a really interesting telehealth story, and it's something that a number of organizations were doing prior to the pandemic, including the one where I work, Mass General Brigham in Boston. And another thing about telehealth, we'll talk a little bit later about reimbursement, but I think you can take to the bank the notion that telehealth is pretty good in a value-based conversation. So if you're value-based already, if you're under risk, if you're thinking about going at risk, as many organizations are these days, really telehealth is going to be a good set of tools to develop in preparation for that. And e-consults is a great example of that, because what it enables us to do is to take the easiest or simplest questions that you might send to a specialist and have those answered with the patient never reaching that specialist. In my case, again, as a dermatologist, the way this works is a primary care doctor takes a couple of pictures with their iPhone, uploads a little bit of history. All this is done through our electronic record. It's all secure. And then we take turns. Our staff rotates a week at a time, and these just come into our in-basket, and we handle them usually within 24 hours. I think our service level agreement is 48 hours, but we try to handle them quickly. And we're doing really triage work. Sure, send the patient right away. Patient needs a biopsy. Try this topical steroid and then report back. Yes, you need to send the patient, but it can wait 6 months or 3 months or whatever the wait time is. Those are the kinds of decisions that we make. And of course, I mentioned the dermatology aspect, but it's happening with all specialists. And these are some of the data from doing this, which again, I think is quite remarkable that we started, I think, in 2016. So let's say 4 years, 3 to 4 years, 80,000 of these across our system. But more importantly, we think we saved almost 65,000 in-person visits to specialists, which again, in a value-based mindset is enormous savings. And the patients, if you explain it properly to them, they like it too, because they don't have to make a separate trip to someone. Primary care ends up owning that patient and owning that decision-making and owning that implementation. Generally, they like that as well. So it's a nice, I think, example of this asynchronous exchange of information being more efficient. And one thing I often say in these presentations, which I haven't chosen to highlight today, but is that, you know, the pandemic is going to go. We're already seeing that, thank God. Telemedicine will stay, and programs like e-consults will be prominent, because even without a pandemic, we still need to be more efficient. We have a supply and demand problem. We have more demand for healthcare services than we have clinician time. And so these kinds of tools enable us to use our clinician time very effectively and efficiently, which is why I tend to spend a little bit of time on e-consults at the beginning. So that's all we'll say about that. But just remember that if you're in that kind of risk-bearing environment or what have you, this is very easy to implement. There are now reimbursement codes if you want to bill insurance. We chose not to. Now, we pay for these out of our risk contract dollars. We pay a modest fee to the clinicians to complete these e-consults. All right, so back to the pandemic, to virtual visits, where we are. And I'm going to spend a little bit of time. I think the data on this particular slide is probably, if you haven't read these factoids, you've read similar ones. And so I don't think reading them is particularly useful. But you can see that during March to June, the world exploded with telehealth, and it was largely virtual visits. And you can see also in here some of the diabetes, 34% by telehealth, total visits declined by 30%. So we had this anomaly where we told our patients, you must stay home and we will care for you by video or telephone. And you know, happily that worked well. But it was an overnight thing. And I think one of the things that I will come back to is that for some people, it gave them a sense that this is really, we can do everything by telehealth. We did everything in person, we flipped a switch, and then we did everything by telehealth. And honestly, a lot of what we want to talk about, especially from a risk management perspective, is what's appropriate, what isn't. And the second theme, which I'll get to in a few minutes, is just how to retrain your staff to handle this sort of thing, because inevitably we're ending up with, and we are now with what we call a two-channel or hybrid environment, where we're doing both telehealth and in person, and that requires some rethinking how we triage, how we train our staff, how we set our patients up, and I'll cover a little bit more about that in the next little while. Now, this is another important one because the idea, as I just said, is that not every specialist is geared for telehealth. So, for instance, at the top of this chart, and I hope you can see it. I apologize, some of the print's a little small. This is a direct lift from a paper that was published in the Commonwealth Fund in May or June of last year. And it's the idea that during lockdown phase, certain specialists had more of a decline in activity than others, which is really kind of the reverse notion of the idea that they could do more telehealth. So if you look at the very bottom of the graph, for instance, behavioral health had a 30% drop in their activity, which means they could do 70% of their activity easily by telehealth. Whereas at the top, ophthalmology, I think it's about a 10% or about 20%, I guess. And again, the idea there is that if you, and the reason I chose this picture is that if you've all been to the eye doctor, you know, you put your chin in about 10 different machines, you can't really do that in your home. And so it's really, the point of the slide is just to remind everyone that not everything is suited to telehealth, and we'll go over that in more detail in a minute, but that for clinicians, and especially again from a risk management perspective, you have to be comfortable with the care you're delivering. And it's okay to be able to say to the patient, you know, I really think you need to come in the office. And maybe we can talk about it in the Q&A if people want to talk more about how you deliver that message and whatnot. But I just want to drive home the point that telehealth is a great tool. It isn't for everything. And again, we'll talk more in a minute about what some of those things are. So this again is a little historic view, and the reason I share this graph, and I won't belabor it, but is just to show that there was a peak in May, April, May, and things drifted back. And now most healthcare delivery organizations that I talk to are suggesting that about between 15 to 25% of their ambulatory activity is telehealth. And we're likely to see that stay. Now, there are some caveats. One thing I'll talk about is the regulatory environment during the public health emergency and how that's enabled telehealth. And again, one of the things we can look forward to in the future about how that might or might not change. But we're back at a point now where, say, 10%-ish of this in this graph, and that's been pretty stable since. As I say, it's anywhere between 12 to 15 to 25% of ambulatory activity, which changes a whole bunch of things that we're going to talk about. It changes your way you, as I said earlier, the way you triage people, the way you train your staff, how you use your nursing staff, how you use your brick and mortar. And those are all really important things to consider, again, in this notion of a hybrid environment. Now, I share this slide for two reasons. One is the information on the right is from MedPAC, and any of you who maybe know MedPAC know that they have not been the most vocal telehealth proponents over the years. But in a recent publication they cited, that's on the slide here, 90% of Medicare recipients who had a telehealth visit were highly satisfied, or sorry, 67% extremely satisfied, 90% satisfied. When you consider that, that's striking when you think about it, that kind of level of satisfaction. And so I use the diagram on the left, and again, this is sort of for clinicians to think about how they're going to decide what types of things they want to handle by telehealth. But this idea of what I call the magic triad of quality, access, and convenience. And quality, of course, as a clinician is your big one. You have to be comfortable with your quality level. You have to be comfortable you can make a medical decision. You have to be comfortable you can implement a care plan with the information you have. And I'm going to say more about that momentarily. Of course, access is huge, right? Access, and that's something that's, I think, making our payer colleagues nervous. And again, we'll delve into that in a little more detail as well. And then convenience. And I think from a risk management perspective, convenience is the hardest one because patients love this stuff, as is indicated here. Sometimes, though, you have to say to them, I don't have enough information. I'm not comfortable making a decision, which throws off the convenience. But it might be, there's a tension maybe between quality and convenience in some cases. So you have to be comfortable with that, and that's okay. And it certainly is better to err on the side of being cautious and safe than not. So with all of that, telehealth is now a household word. And for those of us in the industry, myself, I've had almost 30 years of studying, implementing, advocating for telehealth. It's a new day, but it's only the beginning. Now, we've successfully brought the doctor's office into the patient's home. And again, good news. I don't want to hold anything back, and I don't want anyone who's been excited about that to not revel in the success. And let's face it, the way we were able to do this for the pandemic, God bless that we had this and we didn't have that pandemic 20 years ago when the technology was much more fragile. So all of that's true, but it's just the beginning. And it's a little bit like, I don't know, my analogy quickly is that when Alcoa invented aluminum, I think it was in the early 1900s, people didn't really know what to do with this amazing new material, strong and light. So they painted it to look like wood because they were familiar with wood. And my analogy with the video visit is that's kind of what we've done here. We've taken an analog activity, meeting in an office, we've extended it by video, and we've called that innovation, which it is on one level. But as I said, we have to be rethinking entirely what we do with our patients from a digital perspective. And this is just the floor rather than the sky. So let's turn now, and I promised I would cover this in more detail. What is a telehealth visit good for? What do you, how should you as a clinician make some of these decisions about what you're going to be doing? Well, again, ultimately, you have to be comfortable with it. And now that we're back in a hybrid environment and, you know, fingers crossed, most places in the US in the next few months will have, I think, relatively complete freedom to move about. And because of vaccinations, I know in my own practice here in Massachusetts, more and more people are coming in that avoided care for a year because they now feel comfortable that they're vaccinated, our staff is vaccinated. So that's just a harbinger of things to come. So you're going to have to decide, well, what do you offer for telehealth? And that's your decision. Now, I'd like it if our specialty organizations and whatever specialty you're in, I'd like it if they took a bit of a lead on helping us with this, with what I call use case definition. They may or may not. I don't know. I don't have particularly good insight into that. I haven't seen a lot of it. I do think some people feel like the pandemic came and went and we're going to go back to not a hybrid model. I don't believe that's the case. You're going to have telehealth as part of your practice, I believe, going forward. So these are some of the ways to think about it. The most important thing from this slide is the top sentence. What information do you need to make a diagnosis or render a care plan? And if you don't have to touch the patient to do that, telehealth can be done. It's really, on the one hand, simple. Of course, it's not that simple. There's a lot of nuance, but for most clinicians, I urge you to start there because some of us are used to thinking that, well, I have to see the patient, I have to touch the patient, et cetera. And I've heard all manner of interesting changes in individuals' care over video so that they can get the information they once got from a physical exam. I'll share an example of that in just a minute. So behavioral health is a natural because why? Well, because the physical exam is talking to the patient. Which we're doing essentially with this technology. You can see the patient, you can see them in their own environment. You might be able to get even more information about their behavioral challenges that way than you could in your office. So it's a hit, and that's why that slide I showed earlier showed that most behavioral health professionals are now doing anywhere from 70 to 80, some 90%, some almost 100% of their activities virtually, and they don't plan to go back. In Massachusetts, we recently passed a law and behavioral health came out on top of the reimbursement win game that perpetually in the state, health plans have to pay at parity for behavioral health. That's just one example of how strong the tailwinds behind behavioral health are in telehealth. Virtual urgent care is the second tier, and again, some of the COVID screening comes into this as well. This, again, predated the pandemic, but has become more popular now. And you can see the list of things. It's a little bit like the way we thought about retail clinics 10, 15 years ago, a limited scope of complaints that you can deal with. And then finally, follow up for chronic conditions. One, I think, rule of thumb that's very helpful is the more you know the patient, so it's really two, the more you know the patient, A, and B, the more, I'll call it algorithmic. For instance, let's say titrating hypertension medication is an example where you need to know the blood pressures. And if you know the patient really well, that's perfect for even for asynchronous, but certainly for a video visit. So it's things like that where you know the patient, you're following up on a very specific kind of detail. Now, the next slide is the flip side of things that I think are better handled in the office. What's interesting is this, as time has gone on, I created this slide a few months ago, and I've sort of morphed some of my thinking on this, and I call all of these except the last one, procedures, as relative contraindications, which is interesting because in the beginning, I really felt more comfortable that these things should be handled in the office. And maybe you do too. And once again, you have to be comfortable as a clinician that you're giving quality care. But what's interesting about, for instance, the complete annual checkup is I have a friend, we actually trained together. That's how far back we go. And she's an internist. And I was on the call with her recently talking about this. And she said, and I questioned her, I said, don't you need to do a physical exam? She said, I have all these ways that patients can do things for themselves. I don't listen to their lungs, but I ask them to climb a flight of stairs and see if they get short of breath. Really interesting to think about that. And again, I'm not saying that's good for everybody, but it's creative thinking, and that's kind of what we need. It's back to that notion of, do you need to touch that patient or not? Now, the second part is really, I think, more about planning. And this goes to a larger, I think, theme from a risk management perspective about training staff and preparing for virtual visits. But urge your patients to get any information they have together ahead of time. Urge your staff to give them checklists, to give them reminders. You can engage your patient portal to send them reminders. There's nothing, I think, more deflating to all of us than getting on that virtual call and realizing that you don't have the X-ray information or the lab tests that you need to make that decision. And it's a waste of everyone's time. So I think, although it's, again, a relative contraindication, it just brings up this notion that you really have to prepare people in a slightly different way for virtual care than you do for office-based care. And that includes your staff as well. I think patients with multiple problems, again, it's a judgment call, but I just think it's easier to handle those in person. And I also think the next one is better handled in person. Someone who's got a newly diagnosed cancer, you're talking about their long-term care plan, their prognosis, that maybe there's an end-of-life conversation. Yes, you can do that virtually, but I think it's, if you can, do it in person. I mentioned at this point the differential that distance adds to this whole equation. I work at the Massachusetts General Hospital, and we consider ourselves the community hospital for Beacon Hill and right across the street in Boston. And if someone had any of these, I'd say come in. But we also see people from all over New England, upstate New York, et cetera. I might suggest to one of those people that had to drive 6 hours that we could do it by telehealth as long as we had the licensing worked out, et cetera. So distance makes a difference in those calculations. Right, so reimbursement, I'm not going to cover this in any great detail. I did want to mention that there are reimbursement codes now for just essentially anything you want to do. It's interesting, these are codes that I had the privilege of working on with my colleagues at AMA since 2017. Tristan mentioned I co-chair their committee on digital reimbursement, and we've done all this, which was gratifying because once the pandemic kicked in, people could build these codes. And of course, some of the other things that Medicare allowed us to bill virtually anything. local payers, most local governors insisted that local payers follow suit. So it became pretty wide open, and I'll cover that in more detail in a moment. So yes, there's reimbursement. And as I said earlier, if you're working in a value-based environment, these codes are probably helpful to you too, because they document clinician work, even if you're not billing for them. So I think worth knowing about the codes either way. All right, so we talked a little bit about this, but during the public health emergency, there were three kinds of regulatory, I say relaxation, that really catapulted telehealth in that first part of March or middle of March 2020 to the levels we saw earlier in the talk. And there were these three: reimbursement, technology, and licensure. So you probably all know this by now, but the government said during the PHE that they would not enforce a law called, the law is actually called 1834M. It's also called the originating site rule. It says that if you're a Medicare recipient, you're not able to get telehealth unless you live in a health profession shortage area, and you travel to a clinic where they have telehealth equipment, and the doctor's in a clinic too. Very 1990s thinking. It's all gone away now, but that law still exists. So if you have any, this is just a slight footnote, but if you have any advocacy staff, anybody that you want to, we would love to have you cheerlead your government officials about changing that law. Because after the public health emergency is listed as that law hasn't changed, Medicare, CMS, their hands will be tied. And that's a scenario that I think will put us back, set us back quite a bit in terms of telehealth. The technology bullet is just a quick mention, and I say quick because I think it's been sorted out, about HIPAA. And indeed, during the PHE, they said they wouldn't enforce HIPAA, which means you could use FaceTime, you could use Zoom, you could use Google Hangouts. Most people have really already proactively gone away from that for I think a couple of reasons. One is most of us have found vendors we can work with that do have HIPAA compliant video software. It's actually not that hard to do so. And for the solo clinician who is in a small practice or doesn't have an IT staff, or the one that's quite handy is called Doximity Dialer. Doximity is a free social network for physicians, and they have a tool that's part of it called Dialer, which you can do audio or video calls that are HIPAA protected. And so I don't think there's any real reason to use Skype or FaceTime anymore. Doximity Dialer is very handy in terms of the patients as well. And so, as I say, I think most people have solved this problem, but it was there. And then finally, licensure, which is starting to get thorny again. But so for the last year, 49 out of 50 states had relaxed their licensure requirements. Sadly, there's still requirements. So, you know, in my case, if you're in New Hampshire, I still have to ask the people in New Hampshire for permission to see you virtually, which is of course an added burden. Whereas if you're in Rhode Island and I'm in Massachusetts, I don't have to ask, I can just do it. We have to have uniformity. We at ATA like the regional compact strategy for this. I just got an email from my own general counsel last week that we're going to ratchet back our cross-state activities in preparation for the winding down of the PHE later this year. And it makes me sad to do so, but I understand that by the letter of the law, it's not, you can't practice in a state where you're not licensed. So that's something, again, from a risk management perspective to be careful of. Right now, you're capable of doing it, but you should have a plan. We're in a pretty good, I think, authority from the White House and others that the PHE will last through the end of this calendar year. So that means you got about 8 months to figure something out. It's not that long to do. Maybe you want to get licensed in a few adjacent states. As I say, I wish that there would be these licensure compacts, but I just don't know if that's going to happen in the next 8 months. Some other trends to watch: these virtual visit add-ons. They're just quickly, things like home devices, home lab testing, digital biomarkers. These are all things that are coming in the market that will give you as a clinician more information to go back to what I said earlier, that you'll feel comfortable making a decision about your patient without them leaving the house. They're all out there, worth watching. All of these markets are immature, but they're starting to happen. Asynchronous care, as I said, because we have this issue with supply and demand mismatch, so there'll naturally be more of that. And I'm going to talk in a moment about remote patient monitoring in more detail. This is a good place for me to just mention a couple of other things about office staff, and I mentioned some of this, but the idea of creating tip sheets for your patients, utilizing your patient portal so that you can securely interact with them, prepare them for the virtual video visit. Remind them that they should be in a private, quiet setting than not driving in a car or something crazy like that. You're going to be talking about their health, and you don't want them to have information about them leaked to others around them. And then the quality of information that they're going to gather for you. Now, in my case as a dermatologist, this is a very important aspect because we deal with images, and images have to be in focus. So we actually have nurses right now checking the images as they come in before we have our virtual conversations with our patients. That is what I call a new role. The other role that's changed dramatically, and we need to, and again, from a risk management perspective, to deal with is the role of the person taking the phone call and triaging the patient. I advise you to give them clear direction as to which patients you want them triaging to telehealth and which to the office. That's a use case conversation. As I said earlier, you need to sort that out. And then again, they should begin to prepare that patient if they're going to have a virtual encounter. What is it? How do they do it? Where do they get it? Did they do it over the patient portal, et cetera, so that it goes smoothly when the time comes. I think I've covered most of this. So as healthcare providers, we're really grappling with what we do with our physical plant. I do, for instance, everyone in my practice now does a half day of telehealth. I do mine Tuesday afternoons from my home. I can't imagine that I would go back to a facility to do that. So that uses the overhead different, the physical plant differently. It's really important for us to think that through as we go forward. And as I said, payers really want us to be much more disciplined about not double billing them, especially on the E&M side. So be very thoughtful about that. And they want to keep thinking about, does this really open up access, and does that open access create more claims costs for them? So far not, but they're worried about it. Now, that's sort of the conclusion of the part about the sort of here and now, if you will, and I'm going to go through now in the next few minutes some of the stuff that's in the future. So one thing that is important for us is physician adoption. These four things come from AMA. They come from some survey data the AMA has done now twice, 2016 and 2019. And I like it because it sort of boils down physician anxiety, which in a way is the flip side of the coin of risk management. Is there evidence for whatever intervention that you're doing? I won't say we threw that away last year, but we scrambled a lot and we put a lot of stuff in place because we had to take care of our patients. Now that we're back in a hybrid environment, you should be asking if there's evidence. You should be thoughtful about that. Again, you should be comfortable with the quality of care delivery. I just talked about reimbursement. Of course, that's a concern. We're going to talk in a moment about liability. And then workflow / integration into the electronic record. Those are the four things that are really important for doctors, we found. I mentioned the licensure story, so I'm not going to labor that. There's a link here to the Federation of State Medical Boards if you want to learn more about it. All right, let's talk a little bit about malpractice. And I've talked earlier about the difference between risk management and malpractice. Sort of cut to the chase on this one. This is from 2020, 19, a colleague and I published this in JAMA, no evidence of malpractice case law in telehealth that we could find. We're just redoing that now. And so far, same answer. I know you all know that anything that happened last year that might end up as a claim wouldn't have been captured by either one of these analyses. And I don't mean to imply that we should be comfortable we're not worrying about risk, but also just to say that I think it's not something that you should be paralyzed by. You should be thoughtful about it. And these are the things that I tend to think about when I talk to doctors about liability and telehealth. So I mentioned this earlier, but it bears repeating. Be aware of the tension around quality and convenience. If you feel like you have to interrupt a virtual visit to bring a patient in because of a quality concern, you must do so. It's that simple. Now, the other one is interesting, that this is something that comes from sensitivity that I have as a dermatologist. My colleagues, my dermatology colleagues will say to me, well, but if the patient shows me a bump on the wrist and they have a melanoma in the back that I miss, am I going to be held accountable for that? And the answer is, if you remind them and then document in your note that it's a focused visit, then of course not. Now, that's a sad outcome. You don't want that outcome. But people, they'll make the decision that they want you just to look at the arm. And you might say to them, well, it'd be a good idea to come in once a year for your annual exam to do a full body skin exam, which so far we're not be able to do by video. But not to think that somehow you're going to be held accountable for something they didn't show you when it's obvious that it's a focus visit and you document that. And of course, always, always, always confirm with your malpractice carrier. So as I said, we're going to go down to it. We're going to finish off with really a couple of topics that are, one of them is fairly near ready to launch, remote patient monitoring, and the other two are really speculative, and that was by intent. So go through this relatively rapidly because I think the bulk of what you want to hear about in the day-to-day we've covered at this point. But I do think you should look forward to remote patient monitoring. It just makes sense, again, in this idea of both efficiency that we talked about, supply and demand, in the idea of being an adjunct to virtual video visits for chronic illness management. I mentioned titrating blood pressure medicine before, and of course you wouldn't be able to do that if the patient didn't have a blood pressure cuff. So that's a form of remote patient monitoring. So it just is coming out all over the place. And again, there are reimbursement codes now to support it. This is just an example from our own delivery system for congestive heart failure telemonitoring and how dramatic the results can be. These curves are, the top is all-cause readmissions and the bottom is heart failure-related readmissions. This is before and after data, a year before and a year after a 3-month intervention, which is quite striking. The intervention being on the cartoon on the right, which is the weight scale, the blood pressure cuff, and the tabletop device, which includes, of course, but interaction with the nurse call center, where a lot of the magic happens on this. So very straightforward now in the marketplace, lots of vendors offering this. And again, you can either buy it and save money on the back end from readmissions and efficiency, or you can buy it and bill for it. Either way you like it, it's there. And these are the codes, which, as I said, I don't plan to read this to you, but they exist. These are all detailed on the AMA website if you want to learn more about them. Digital therapeutics is, now we're getting into stuff that's really up and coming and not not solidified yet. The idea here is that a mobile app, or sometimes an app coupled with a device, when given as an intervention to a patient, can yield a therapeutic result that is as good as or better than a conventional medication that you would either inject, infuse, or give by mouth. Now, a lot of this is behavioral. A lot of it is things like mindfulness, behavioral health, online CBT. The second company mentioned here, Akili, is a company that has a game for ADHD patients, which is quite effective. And so Happify is a mental health, another mental health company. Pear has, for instance, two apps. These two are, one of them is for substance use disorder, the other one is for opiate use disorder. So that tends to be where a lot of these are. But there are other ones that are coming into the marketplace that are more specific to, as I say, pairing a device with an app and doing other kinds of illness management. Right now, there's no accepted way to put these in and pay for them. And that part, that's making or causing the proponents in the industry to really dig in and figure out, is this something that's like part of a therapeutic benefit? If they're calling themselves therapeutics. Some of them have come to us at the AMA, the committee that I chair, and talked about whether they should be remote monitoring codes should be supporting this. And so right now, the big hurdle is not so much evidence, because at least the companies that I showed in my last slide have pretty good evidence that their stuff works. And it indeed is as good as, or maybe even better in some cases, than a chemical therapeutic. But it's how to fit it into the workflow, how to fit it into the reimbursement schemes, how to get it paid for, whether it's a direct to the health plan thing for employees, whether it goes through the doctor as a prescription. All those things have to be worked out. So stay tuned, but I would urge you to read about it, think about it. We're just now looking at some reimbursement codes. If those come through in the next, I would say probably the earliest you'd see them is 2023. That's my guess. Then, the market will start to coalesce around those, and you'll see more and more of this stuff in the market at that time. So finally, AI, and I don't know, everyone's a little bit different, but a lot of people I talk to, especially clinicians, are quite concerned about AI. They're quite concerned that it's maybe a big malpractice risk, that it's taking away judgment, that it's somehow putting them at risk. And of course, you get these headlines, one of which I'll share later in my own specialty, the idea that an algorithm could diagnose melanoma as good as or better than a dermatologist scared a lot of us. And so what I start out by saying here is that artificial intelligence doesn't do judgment, it doesn't do caring, it doesn't do emotional intelligence. All those things that make you unique as a clinician, it doesn't do. So don't be afraid of it. What it does do really well is look at large data sets and cull out trends and patterns, things that we as people don't do well at all. And there's a really interesting discussion about bias, which I'll just briefly mention. But on the one hand, a lot of people now are concerned about bias in AI. Let's say you trained a data set to recognize, well, in my case, let's say skin lesions, and you just forgot to leave, or you either forgot to include or you left out intentionally skin of color. That's a screwed up algorithm, and it won't work well, and it will misdiagnose people. There's a famous MIT, I think she's a faculty now, she was a grad student at the time, who has a TED talk showing that facial recognition software would not recognize her African-American face. She had to put a white mask on to get it to recognize her. So there's that, but there's also the flip side, which is we as human beings, there are about 160 ways that we bring bias to any given decision, whether it's recency, anchoring, and I'm sure those of you've studied, you've read about these, they're fascinating. The whole area of behavioral economics, I find it fascinating. So if we get the AI right, it will cut through all of that and give us just pure data that we can work with, or I should say insights from data that we can work with. Let me tell you a story I think that illustrates that, and that's listed here. So this is about an algorithm that was working on lymph node biopsies to detect breast cancer, metastatic breast cancer cells. And the way it works is that the AI algorithm alone, the story is anyway, this published paper, detected the METs 92% of the time, which, you don't really know if that's good or not, right? But it turns out that the pathologists were better, 96%. So that day they went home happy. They didn't feel like they were going to lose their jobs to a computer. What someone though did then, and that became the focus of the paper, was they used the algorithm to lift up and tee up the complicated cases. And together, when they did it together, they were 99% accurate. I think this is one way we can really think about AI, and I urge you to start thinking about it in that way. The other way is illustrated here, and this is from the ophthalmology literature. And as a company, this has now been commercialized. It's a diabetic retinopathy screening tool. It's another tool that you stick your chin into, as I had said earlier. But this one's meant to be in the primary care office, and it's going to guide the primary care doctor to triage you to ophthalmology or not. And once you do that, it's going to allow the primary care doctor to bill, because this code just went through the CPT process for this. And I think of it as essentially like a lab test, like a CLIA lab test, like a in-office strep test or an in-office CBC or what have you that a primary care might do. It's another tool in their armamentarium to help them make a clinical decision. They're going to make the decision. The AI doesn't make the decision, but it's going to help them. And so that's another way to think about AI in healthcare. In any case, it's coming. It's the amount or the acceleration with which this technology is being dealt with is unprecedented. We've never seen anything like it. So do follow it along. Tristan mentioned I'm editor of the journal NPJ Digital Medicine. About 50% of what we publish is in this field. It's rapidly moving and very exciting. And if we do it right, it will help us make better clinical decisions. So that's where we are. We have a whole bunch of solution pieces. I think in the next 10 years, you'll see this much more uniform. Everything from chatbots here to digital therapeutics to robots to telehealth to computer vision. They're not unified. They're not part of a unified digital approach to patient yet. That's the next phase, really, is putting them all together in that regard. And this is my contact information, as I promised. And I guess we've left maybe 7 or 8 minutes for questions if there are any. And thank you very much for your attention.
Thank you so much, Dr. Kvedar. That was a wonderful presentation. To the audience, I welcome you. I'm Jerry Donahue. I'm the Vice President of Education. And yes, there are some questions. First question is Apple FaceTime HIPAA compliant?
No. Simple answer, no. No, I mean, and that's because Apple has not gone through the process of deciding that they would sign a BAA and so forth. That probably is encrypted. I know Skype, for instance, is very well encrypted, but once again, HIPAA compliance and encryption are two different things. Encryption's technical, HIPAA is a statute.
Thank you. The next question, how would a clinician know each state's specific rules on telehealth?
So unfortunately, it's work. You have to go to that FSMB, Federation of State Medical Boards.org, and they can guide you for the states around you. It's not unfortunately not an easy task.
So those are the questions that have come into the chat during our time together. We can probably give it a moment now that some questions have somebody else looks like they're about to ask another question into the chat. We can just give this a moment.
The question is, when my patient sends back and forth messages on my practice portal, does this count as a billable asynchronous visit? If so, what is the CPT code?
Yes, sort of. So, you know, we're still in the journey. As I said earlier, it should, and you can make it do so, but you have to do some things. You have to, first of all, get the patient's permission to bill the insurer, as you would any other time. Now, we don't even think about this because people walk into the office and your staff asks them to sign a paper, but this is virtual. And so they have to be informed that you're going to bill insurance for the activity in case there's a copay, in case. That's the main thing. And then you have to make sure you have a structured note that documents that you did the work. So if you do those two things, yes. I apologize. I don't have, I mean, it's in one of my slides, which I don't know if you folks are going to make the slides available, but there's a wonderful set of tools on the AMA website. If you just go to the AMA website and put in telehealth billing, it'll pop up and you'll be able to see the codes.
Thank you. In the absence of any further questions, I have a question. I wondered, with all of our physicians that are on the call today that are likely practicing telehealth, if you could offer one, I guess, suggestion or recommendation that could best protect our physicians from medical malpractice litigation, what would come to mind for you?
Well, it's just to reiterate, it's what I said earlier, which is you need to be comfortable you're delivering quality care and you have the information you need to make a decision, whether it be a care plan decision or diagnostic decision, and to be aware of that tension between convenience and quality, that sometimes quality means doing things twice, sometimes it means delaying, sometimes it means bringing people into the office or even sending them to urgent care or the emergency room, and not to be afraid to do that.
This has been amazing information, Dr. Kvedar. I think your expertise is just exactly what I'm looking for. And I think your punishment for doing such a great job is that we're probably going to be inviting you back here again soon.
Well, I'm delighted to have been with you. I do have another call at the top of the hour, so I'm going to drop off at this point. But I really enjoyed it. And again, if other people have questions, they can send me emails or connect with me on social media.
That's great. And just want a word out. Thank you for during this time advocating for physicians to get compensated for telehealth, because I mean, especially during the pandemic, it's really just been a critical thing. So just thank you.
Bye-bye.